Good evening. Thank you, Mr. Chairman. I'm going to present a case of RCA CTO. My patient is a 45 years old male patient with multiple risk factors and strong family history. The patient had class 3 angina despite receiving maximal or optimal medical therapy, and he had a history of admission for unstable angina ACS and admission to coronary care unit 1 month back. The patient had history of PCI 2 times before for PCI LAD and circumflex 3 years earlier. Echocardiography on admission at that time, it was normal with normal ECG and angio performed 1 month back. It was mid-RCA CTO with distal CERC CTO ISR. So the patient referred to us for CTO PCI, and we started with femoral and radial, right femoral, right radial approach, using 6 French AL1 for the right coronary artery and EBU 7 French or CLS for the left system. This is the RAO shot for the right coronary artery, and this is the left system angiography. And this is the bilateral angiography. This is the left shot with a delayed, actually it is so delayed right injection. And from this bilateral injection, we conclude that the JCTO is almost 3 to 4. It's a relatively long side branch and some calcifications. So how to approach this CTO? We have a global algorithm how to cross the CTO, and it depends on the proximal cap ambiguity, the distality of the vessels, the presence of good collaterals. So our case, as previously we saw it, the proximal cap, it is relatively ambiguous also, most probably at the site of the RV branch that continues as an accessory PDA. But here in this situation, IVAS would be very good option to do penetration of the proximal cap, but at that time the IVAS was not available or accessible in the cath lab. So we said, okay, just we inserted, I started to insert the polymeric wire in the RCA, and the patient started to develop severe chest pain, hypotension, bradycardia. And always we say when we go for a CTO, you should be very well prepared, you studied very well the angiography. So we started with just insertion of the wire. The patient really got severe chest pain, hypotension. This is a fluorostor, and we gave a small injection. This is a pilot 50 wire. My wire, it is subintimal. It was not clear whether the guide induced this passage of the wire. So I started to insert another wire, workhorse wire, BMW wire, and we implanted one 4 millimeter DES to restore the flow into that RV branch, and the patient, the vitals become stable and the chest pain started to relieve. And now we started to change to retrograde approach. This is the left shot. There are some promising septals, septal 2 and septal 3. The second septal, it arises at the site of the stent, but the third septal, it is very good, although the ostium, it is somewhat tricky. And we started with inserting workhorse wire with the Corsair microcatheter, Corsair Pro, and there is connection, but it is tortuous. We started with the SO 03 wire, and some time to give it, and just jumped distally into the RCA. But the problem that I faced at that time, after we confirmed the position of the SO 03, I could not advance my microcatheter distally. But I did manipulation of the wire, and I was surprised that SO 03 advanced for a very long distance, and almost it is reaching the proximal cap. And I started to give some antigrade injection to confirm the site of the proximal cap in different views, LAO, RAO, and lateral shoots. And now the proximal cap, it is almost clear. And since I was unable to advance my retrograde microcatheter to change for a stiff wire to penetrate it, I kept my wire there, I removed that microcatheter and inserted 1 millimeter balloon as a protection over that wire in the septum, and I came antegrately with the Gaia next third with same Corsair Pro microcatheter, and I did puncture and I followed my retrograde wire, and it was moving very nicely. This is the retrograde injection to confirm the position of the antegrade Gaia next third wire, and it was in the true distal lumen. And now I tried to advance the microcatheter, but the microcatheter could not be advanced more, so I changed microcatheter to 1 millimeter balloon with the support of Godzilla. We were able to cross the proximal cap, we do some dilatation, and then we changed the wire to workhorse wire, and we deployed some stents, some post-dilatation, and we restored TIMI3 flow in the right coronary artery. Then we moved to the LCX CTO ISR because the material was already there, the same microcatheter and the same Gaia next third. We penetrated and changed to workhorse wire, and we deployed some DCBs at the site of the occlusion, and we restored TIMI3 flow in the LCX ISR CTO. So the take-home message from my case, pre-procedural planning is the key for success in CTO PCIs. Switching between strategies will always lead to procedural success. Bilateral approach, good guide, and wire selection was the main reason for revascularization. In such complex procedures, CTO careful monitoring is required for early detection of complications, such as in our case, which was from beginning we had an RCA dissection. And thank you very much.
Excellent. Thank you very much.